Please begin.
Hello, and good evening or good morning, depending on your time zone. My name is Carolyn Dressler, and I would like to welcome everyone to the International Association for the Study of Lung Cancer webinar on smoking, cessation, and the cancer patient. IASLC is the only global organization dedicated to the study of lung cancer and has nearly 4,000 members in 80 countries. IASLC members promote the study of etiology, epidemiology, prevention, diagnosis, treatment, and all other aspects of lung cancer and thoracic malignancies. IASLC disseminates information about lung cancer to scientists, members of the medical community, and the public, and uses all available means to eliminate lung cancer as a health threat for either the individual patient or throughout the world. Membership is open to any physician, scientist, nurse, or allied health professional interested in lung cancer, including patients, survivors, caregivers, and advocates. With this webinar tonight, we hope to share information with you that will provide the background knowledge for why it is so important to help patients quit smoking. Note, this is not about the causation or etiology of lung cancer. Rather, it's about the most effective treatment for lung cancer. When you have listened to Dr. Warren's presentation, you will better understand why I emphasize that helping patients stop smoking is one of the best interventions we can do in treating patients with lung cancer. Please note that we will be monitoring the questions that are submitted online. We will address as many of the questions as we can when Dr. Warren has completed his presentation. So submit your questions as you think of them. I'm very pleased to introduce our expert speaker tonight, Dr. Graham Warren. He is a practicing radiation oncologist and is Vice Chairman for Research in the Department of Radiation Oncology at the Hollings Cancer Center of the Medical University of South Carolina. He is also a toxicologist with an active research laboratory in the Department of Cell and Molecular Pharmacology. He is one of the most active researchers in the field of tobacco use effect in the cancer patient, in addition to his tireless scientific advocacy work in major cancer organizations such as IASLC, ASCO, or AACR. I am very pleased to welcome Graham Warren to this webinar tonight. Take it away, Graham.
Well, Carolyn, thank you very much. I very much appreciate the introduction. I will apologize ahead of time. Unfortunately, I've got a little bit of a smoker's cough without all the benefits of smoking, so I'll be hacking a little bit during the call, but hopefully we'll get through it well. As we start, will be talking about the importance of smoking and the cancer patient, as Carolyn discussed, and hopefully we'll persuade you of some of the clinical and biologic effects of smoking on the cancer patient and some of the rationale as to why we need to address this on a much larger scale. As a part of my disclosures, I do have funding for the American Cancer Society and supported by the National Institutes of Health, whereas I do have participation in the tobacco subcommittees and committees for ASCO, AACR, and IASLC. I will be giving information that's based on evidence and does not necessarily represent those parent organizations. In addition to which, I don't receive any funding from the tobacco industry. I have no patents, royalties, payments. I won't get anything financially from what I'm going to tell you tonight. When we talk about cigarette smoke, we know, particularly with regards to lung cancer, that cigarette smoke is the largest single contributor to certainly lung cancer and overall cancer risk. There's been increased discussions about how obesity is increasingly associated with cancer, but I think smoking at this time is still the most significant preventable risk factor for the development of cancer as a whole. And when you look at cigarette smoke, there's over 7,000 constituents in cigarette smoke, including several known carcinogens, and there's a large number of additives. And these additives are included to try and increase absorption, flavor, and addiction. And this is one of two of my favorite slides. There's over 600 chemicals added to cigarettes. Then you light these chemicals on fire and you inhale them. And so it's no wonder that there are significant adverse health effects associated with smoking. And when you look at some of the things that are added, you can see there's strange things like acetic acid, ammonia, apple juice concentrate. I'm going to show you with this little yellow arrow some of these things throughout the slides. And these additives, again, are to try and increase absorption, flavor, and addiction. And then what I did was I actually put the entire list of 600 additives that are known to be added to tobacco. So this is what I consider a fairly convincing argument of the adverse effects of anything that has this many constituents that you light on fire and purposely inhale. Well, the net effect of this is that we know lung cancer is one of the consequences associated with smoking. And at least in the United States, there's been a lot of research looking at how smoking prevalence and lung cancer affects mortality rates. And this is one of the well-known slides actually from the 90s that demonstrates that here in the southeastern portion of the United States, where all this brown tobacco-colored country is, there's a very high prevalence of smoking and, of course, a very high prevalence of or incidence of lung cancer deaths attributed to smoking. And if you look at the reasons why, well, if your mother smokes or your father smokes, your brothers and sisters smoke, well, then you're going to smoke. It's the environment that you're exposed to that predisposes you to smoking. Now, I'll just let you know ahead of time, I did not have any babies pose with a cigar. This is penciled in, but hopefully you'll realize that the influences of society as well as marketing practices result in the uptake of smoking at a very early age, which unfortunately continues as an addiction through most of a person's adult life. And this is evident. This was actually taken and I'm in South Carolina right now, in November of 2013 at a candy store next to a movie theater. I took a picture of candy cigarettes that were present right next to the movie theater. So this is a good example of how marketing kind of targets the youth to try and use tobacco at an early age. This is something that's increasingly prevented, but is still something that has to be considered. Well, we know that smoking causes cancer, lung cancer in particular, and there's been very well-established biologic models for the effects of smoking on developing cancer. There's a series of mutagens that are introduced. You get DNA mutations that lead to progression and development of cancer. However, one of the things that is not necessarily very well known is that after a cancer diagnosis, that continued smoking has significant negative outcomes. In the 2014 Surgeon General's report that presented evidence on approximately 400 studies from over 500,000 patients, there was an evaluation of the effects of smoking on mortality, recurrence, risk of second primary cancers, toxicity, and recurrence in response to treatment. The really striking relationship was that the conclusions from the Surgeon General's report was that in cancer patients and survivors, the evidence is sufficient to infer a causal relationship between cigarette smoking and adverse outcomes. Now, this is a relationship that has gone through 15 different levels of vetting for evidence review. So for the Surgeon General to conclude that smoking causes adverse outcomes is really a profound statement. In this case, the adverse outcomes are known for a causal relationship between all-cause mortality and cancer-specific mortality. So you not only increase the risk of dying from cancer, but you increase the risk of dying from things other than cancer, such as heart disease or pulmonary disease. The effects of smoking are also known to cause adverse health outcomes such as increased risk of second primary cancer and increased risk for, or increased association with risk for toxicity and recurrence. And I apologize, I think I've gotten off by one slide here. No, I apologize. I've missed a slide in here. But the association with continued smoking also exists for increased treatment toxicity, risk of recurrence. Now, those are not known to be causal, but they're strong negative associations with smoking and those outcomes. So the net effect is that when you look at the magnitude of what smoking does on outcomes for cancer patients, when you look at overall mortality here, you can see that current smoking has a 51% increase in overall mortality as compared with a 22% increase in risk of overall mortality in former smokers. As related to cancer-related survival, current smoking is associated with a 61% risk, whereas former smoking is associated with a non-significant risk. And so when we look at smoking, we need to look at more than just an ever smoking history. It's very important to consider current smoking status as well as a former smoking history when we look at how we treat and intervene on cancer patients' behalf. And if you think this is just associated with tobacco-related diseases, well, unfortunately, the effects of smoking are prolific across virtually all cancer disease sites. For hematologic, breast, gynecologic, this is just a graph taking a look at the studies in the Surgeon General's report that show in the red bars the number of studies that have significant negative association with smoking and outcome. And if we focused on lung cancer, we have about 75% of all studies show one or more negative outcomes associated with smoking in lung cancer patients. So you might think to yourself, well, smoking is something that we need to address, but perhaps it's something we can address after we've treated cancer. Unfortunately, this is one of my favorite examples to give. There was a nice evaluation of the effect of smoking in patients with Hodgkin's disease with regards to risk to developing a second primary. And I like this because this really shows that smoking, when combined with a cytotoxic therapy, significantly increases the risk of developing lung cancer. When you look at radiotherapy alone or chemotherapy alone, or if you look at smoking alone, then the risks associated with developing a second primary cancer are still significant, but are much lower than if you combine smoking with radiation, smoking with chemotherapy, or smoking with radiation and chemotherapy. And so when we introduce a cytotoxic event such as radiation or chemotherapy, smoking can significantly increase the risk of developing a second primary disease. And I know that this is a lung cancer group, but in prostate cancer, whereas most lung cancer patients unfortunately pass away from lung cancer itself, most prostate cancer patients, in contrast, actually pass away from something other than prostate cancer. And this gives an example demonstrating that in about 1,300 prostate cancer patients, less than 10% of prostate cancer patients died of prostate cancer itself. 90% died of something else. And when we take a look at the risks of current smoking in these patients, we can see that current smoking significantly increased the risk of dying from something other than prostate cancer. So arguably, you could say that smoking itself may be as significant as some of the treatments that we employ for our cancer treatments are significantly impaired by smoking, and smoking may actually have a more significant outcome than the treatment itself. So we know that smoking causes these adverse outcomes in cancer patients. The 2014 Surgeon General's report it really has a very nice causal association. So I think we can rely on the significant evidence there to say that smoking is bad for cancer patients. If we started to try and look at the biologic effects of smoking on cancer cells, we can generally try and summarize the effects of cigarette smoking according to the immediate signals and activating agents in cigarette smoke that would stimulate a series of intermediate cellular signals and downstream signals that manifest in cellular effects. And this, unfortunately, is something where we don't have a great deal of information on the effects of cigarette smoke on cancer cells themselves. But the effects we do know is that cigarette smoking and tobacco products increase proliferation, angiogenesis, migration, invasion. Basically, they make tumors much more malignant and more aggressive. And I'm going to focus for just a minute on the nicotinic acetylcholine receptor, because the nicotinic acetylcholine receptor is a wild-type, normally expressed receptor present on all cells in the body as well as all cancer cells. And there's several different isoforms of the nicotinic receptor. But if we looked at stimulating the nicotinic acetylcholine receptor itself, there are a significant number of oncogenic pathways that are activated by the nicotinic receptor that, again, lead to decreased apoptosis, increased migration and invasion, increased proliferation, and increased angiogenesis. So we have, in this case, a mechanism of activating fairly widespread receptors present on normal and cancerous tissues that can lead to a more malignant tumor phenotype. And this is a slide that shows nicotinic receptor activity in cancer cells, But this is the exact same effect that we see in normal cells. So cigarette smoke can stimulate systemic receptors that develop a more intrinsically aggressive tumor phenotype in the cancer cells themselves, as well as in the normal tumor microenvironment surrounding the cells. And the reason this is important, this is one example of what activation of the nicotinic receptor can do with regards to response to radiotherapy and chemoradiotherapy. And in this experiment, there were tumor xenografts in mice, lung cancer xenografts in mice, where mice were treated with radiotherapy, and tumor regrowth curves were demonstrated here with this black line. And this is for radiotherapy and the exact same type of relationship with chemoradiotherapy. But when we activate the nicotinic receptor either just during radiation or during and following radiation, we see virtually identical tumor regrowth curves. And this is true for radiotherapy as well as chemoradiotherapy. Now, the reason this is important is because specifically activation of the nicotinic receptor during radiotherapy or during chemoradiotherapy appears to be the important determinant for therapeutic response. And when we take a look at the reasons why, well, we focused on several different proteins. And when we look at activation of proteins, we looked at HIF-1 alpha. There's several different downstream signals, but HIF-1 alpha was a very nice non-phosphorylated target that would give us an idea of downstream signals activated by cigarette smoke and nicotinic receptor. And here, we're looking for basically black nuclei or dark nuclei in xenografts. And these xenografts were run in parallel with the tumor response curves that we showed above. And in control xenografts, essentially HIF-1 alpha was negative. However, when we activated the nicotinic receptor, just for about 6 days, we had significant activation of HIF-1 alpha at this tumor stromal interface. It's a very unique characteristic pattern where we activated HIF-1 alpha in about 5 or 6 cell layers deep, and this is in the area between the viable tumor pointed here and the stromal interface associated with inflammation in necrotic cells. However, what's very interesting is that when we removed activation of the nicotinic receptor for just 2 or 3 days, these effects reversed. As a matter of in this case, this slide actually would be significantly worse than control xenografts. You can see some black nuclei there and some black nuclei there, but clearly this is very different than the slide I just showed you. So the purpose behind this was to show you that activation of the nicotinic receptor could cause adverse outcomes in regards to therapeutic response, and more importantly, that some of these effects can be reversible within a short period of time, which really suggests that there's a biologic rationale for smoking cessation to improve therapeutic response. Now, why is this important? This is actually unpublished data, but I thought for this seminar this would be very important because these are the only studies like this of its kind. We took lung cancer cells and actually several different cancer cell lines, and we treated them with chronic cigarette smoke, and we treated them with radiotherapy and chemotherapy as well. I've highlighted radiotherapy here. And what we see is that in cancer cells treated with cigarette smoke, we significantly increase survival fraction following radiation, which means that here we significantly decrease the effectiveness of radiotherapy as compared to control cells here. However, in this category here, what happened was we took these chronically cigarette smoke exposed cells and we removed cigarette smoke exposure for 3 weeks. And what we found out is that in some cancer cells, we had a partial restoration of therapeutic response, whereas in other cells, we had a full restoration. So the effects of removal of cigarette smoke appear to reverse and improve therapeutic response. However, the addition of nicotine, in this case, if we took cigarette smoke exposed cells by themselves, which means that we've taken these group of cigarette smoke exposed cells, we've normalized them to a 1. When we add nicotine, in some cancer cells, it appears that nicotine makes therapeutic response much worse, whereas in others, it doesn't have any significant effect, which means that the addition of nicotine is likely safe in some cells and may not be safe in others in cells that have been exposed to cigarette smoke chronically and then removed. What's really interesting is that this is when nicotine is added immediately after removal of cigarette smoke. And in this case here, this is where nicotine is added after a 3-week delay. and you still see differences in specific cells with regards to therapeutic response. This is a fascinating and really interesting time-dependent exposure model. You all will see this in the very near future, but I thought for this presentation it was important to highlight that the reversible effects of cigarette smoke are, one, important, and two, there may be a very unique cancer biology that can help us predict what cells may be more responsive to therapy and what cells may be more affected by nicotinic receptor activation. Now, if you're thinking to yourself, I don't know what to do about nicotinic receptor activation, we've thought in detail about this effect. And with all the pathways I showed you before, if we focused on activation of phospho-AKT, which has been associated with decreased therapeutic response, I only want to highlight here that activation of the nicotinic receptor consistently activates phospho-AKT and downstream signaling pathways that decrease response to radiation and chemotherapy. However, if we looked at bupropion, which is also known as Zyban or Wellbutrin, we can significantly dose escalate bupropion at several different concentrations, and we do not decrease the effectiveness of radiation, and in fact, we're looking at survival fractions here. At super therapeutic doses of bupropion, it actually sensitizes to the effects of radiation. So here we have a cessation agent that does not activate the nicotinic receptor, that does not appear to change sensitivity to radiotherapy, and the same thing with chemotherapy. And when we look, when we look at activation of phospho-AKT, we can see in a significant dose escalation model that the addition of bupropion does not activate phospho-AKT. Again, this argues for a possible biologic rationale for how we approach cessation agents in our cancer patients. Now, unfortunately, we've looked to try and see what is the current state of affairs for assessing tobacco use in cancer patients. And in 2012, we looked at this and published this in the Journal of Clinical Oncology. And unfortunately, we demonstrated that 71% of actively accruing clinical trials had no assessment of tobacco whatsoever, and only 4.5% had any assessment of tobacco at follow-up. So this demonstrated that in our cutting-edge clinical trials, even though smoking affects therapeutic outcome, toxicity, recurrence, survival, unfortunately this is an effect modifier that we're not capturing in our clinical trials. So we said next, well, if we're not doing it in our clinical trials, what are the current practice patterns for oncologists? And we had 3 different surveys. 2 of them have been published. One is a survey with IASLC, which many of you hopefully saw and really enjoyed and completed. We had a very similar survey sent out to ASCO, and then we just completed a survey of NCI-designated cancer centers. And what we did was we asked providers if they asked about tobacco use, if they asked patients if they would quit, if they advised patients to quit, and if they did anything to provide cessation support. And unfortunately, we show that while 90% of these respondents, these are 3 different surveys, very consistent, 90% of patients ask about tobacco use, 80% ask patients to quit smoking, but unfortunately, less than 40% of clinicians actively provide cessation support, which is unfortunately a clinical failure. We're doing a good job of identifying tobacco use, we're just not doing anything about it. And what's really surprising here is that in the IASLC and the ASCO surveys, 90% of respondents felt that tobacco affected outcome, and it was a good thing to incorporate as a clinical standard of care. So these were actually very motivated clinicians that asked about tobacco use, but unfortunately didn't address tobacco cessation in their clinical practice. Now, I'm going to focus on this NCI-designated cancer center survey. The reason we performed this 3rd survey was because in the first 2 surveys from IASLC and ASCO, we asked about practice patterns. And we identified specific factors associated with decreased assistance to try and quit. And when we looked at what were the barriers associated with providing cessation support, we really identified, with regards to discussing medications or actively treating patients, we found that the lack of time for counseling, lack of training or experience, and lack of resources were the primary determinants associated with a decreased activity in treating patients. So we developed this NCI-designated cancer center survey to say, well, if we tried to provide solutions to this problem, if we tried to help you provide cessation support, what would you prefer for us to try and provide? And here we found we're very happy to see this. When we asked providers, when do you prefer to start cessation assistance, 71% said immediately time of consult, which was very good, and very few said that we should start during follow-up. So this is a positive pattern. However, unfortunately, we found that only 10% of respondents felt that they had adequate training in cessation support. And when we asked specifically what education would you use to try and increase cessation support, 55% of respondents said train someone else in my clinic. And we follow this up again with two additional questions. We said, well, if you had the option, who would you prefer to provide cessation assistance for the cancer patients that smoke? Unfortunately, only 1% of respondents stated that they preferred to provide cessation support themselves. 50% said any other clinical staff, including primary care physician, some other MD level provider, a mid-level provider, or someone else. So essentially 99% of respondents said have someone else do this other than me. We embedded another question where we said, what type of, if we were to give you a dedicated cessation program, what type of a dedicated cessation program do you prefer? Again, only 1% preferred to treat patients themselves. Most people prefer training, using trained clinicians inside their parent institution. Only about 3% supported using trained clinicians outside their institution, and about 38% said inside or outside, it doesn't matter. I just know that I don't want to provide cessation support myself. So this unfortunately demonstrates that we may have motivated physicians, we may ask about tobacco use, but unfortunately we're not doing a very good job providing cessation assistance. It also suggests that we need to consider the development of programs to help provide cessation assistance for oncologists rather than relying on oncologists by themselves to provide cessation support. So this was actually a work that we published in Cancer of earlier this year. Now there's several different mechanisms you can use to develop a dedicated cessation program, and I'm going to go through some of the thoughts about that in a few slides. But I want to show you the possibilities that can be employed to increase access to cessation support. We developed an automated tobacco assessment and screening and treatment program where all new patients were assessed for tobacco use when they were new patients. If they were screened negative for tobacco use, they had a clinical standard of care for the cancer treatment, and then they had follow-up screens, and this cycle continued indefinitely. However, if they had a positive screen for tobacco use, all patients were automatically referred to a cessation service. We did not ask patients if they wanted to be referred. All patients were referred to an automatic cessation service. Those patients who accepted enrollment were then provided individualized tobacco cessation and treatment. Those who refused enrollment were entered into a follow-up program where they would be screened again and still be given the opportunity in the future in this cycle to participate in the program. So the key here is that all patients were assessed and all patients were automatically referred to the cessation program. In this program, we screened about 12,000 initial patients. We had 2,700 patients that were referred to the cessation program. Unfortunately, we only had very limited staff. So just by nature, about half the patients were, we tried to contact at least half of the patients with 5 cessation contact attempts, and then we had about another half that we just didn't have time to contact, so we sent them mailings. Now these were only triage based on the new patients that came in every day. We just called them from the top of the list down, so there was no bias in regards to who we selected. Now, unfortunately, people who received mailings, only 1.2% of patients who we sent mailings to contacted the cessation program, which really suggests that sending mailed support is not an effective way to get smokers into a cessation program. But in the people that we did a mandatory assessment and we tried at least 5 contact attempts, we were able to contact 81% of patients. And importantly, of all the patients we contacted, only 2.8% of patients refused participation in the cessation program. This means that patients are receptive. Now, these are all cancer patients. All these cancer patients were receptive to intervention. It doesn't mean they quit. It just means that they're receptive to intervention. And this takes away the rationale that patients are not interested in participating whatsoever. We also found that we had several different screening questions. We had 6 different screening questions that were based on evidence with regards to what questions we would use to capture patients for cessation support. And of these 6 questions, we really found that these 3 questions at the top captured a total of 98% of patients, which means that just a few questions can have a very high potential yield for capturing tobacco use assessments in the clinical setting, which really kind of gives us a target to identify patients that are eligible for cessation support. Now, this next slide was actually presented in abstract form and is currently under review, and so what you will hopefully come out in publication very soon actually shows the longer follow-up data. But we took patients in this mandatory automatic assessment and referral program, and we took all the lung cancer patients who are current smokers, and we looked at the current smokers who came into the program, what were the effects of tobacco cessation on mortality. And this was adjusted for age, pack year history, time between diagnosis and treatment, gender, stage, ECOG status, and histology. And what's very significant to see is that people who quit smoking, we used as a reference category, when we compared mortality, we found that people who were current smokers had a much higher risk of mortality as compared to people who quit. So essentially, quitting smoking significantly reduced mortality. And you'll see follow-up results that were obtained through review of May of 2014 that are currently under review, and I would encourage you hopefully to look for that paper in the coming few weeks or months that will demonstrate the benefits of what a low-intensity cessation program may be able to do. So, how can we try and apply this to a clinical setting? Not all cessation programs are built for all clinical settings. Some clinics may have more resources, some may have less. Some may have trained personnel, others may not. And so when you think about creating a tobacco cessation support approach for patients, it's important to consider the method of screening, such as whether you're going to do electronic, paper, screening by physicians, biochemical testing, what types of things you can consider. You also need to consider what is your method of cessation support. You know, the keystones are behavioral counseling and pharmacotherapy. But some places, for instance, may only be able to provide behavioral counseling and not provide pharmacotherapy. The best is to provide both, but again, this has to be individualized to different centers. Next, you have to consider how is this cessation support going to be delivered. Are you going to deliver this by phone or in person in a cancer clinic or in a separate clinic? And in this case, when this program we have performed at Roswell Park, the automated cessation screening program, we chose a separate clinic specifically because our clinics were so busy that we wanted to take patients out so they could focus on cessation and not slow down clinical flow in the thoracic and other clinics in the cancer center. But again, this would depend on the cancer center itself. Also need to consider providers for cessation support, whether physicians or other health professionals or dedicated cessation specialists would be best for cessation support. I would also encourage to very seriously engaging and considering what type of institutional support is available. I would absolutely suggest and recommend that all patients should be screened and all patients who use tobacco should be referred to a dedicated cessation specialist. The treatment should use evidence-based cessation support. You also need to consider the support of referring physicians, clinical staff, and administrators. You want to make sure that you get support from the people who run the institution so that you can have a sustainable program that's dynamic, that can adapt to clinical problems that might come up and still provide a good clinical service. Financial support for a cessation program. Some programs are supported by state funds. Others are supported, unfortunately, by research funds. Cessation can be billed for in the United States, but in this case, I would very much offer the suggestion that given the known adverse effects of smoking on cancer treatment outcomes, that the financial benefits of supporting cessation are likely significantly outweigh the financial consequences of adverse outcomes. Also incorporating cessation into standard clinical practice and making sure that you have effective communication among administrations, clinicians, and providers. Just recently, Ellen Gritz and Ben Toll and myself updated the chapter on tobacco cessation in DeVita's Principles Practice of Oncology. It just came out about 2 months ago, where we really tried to look at the global picture. And in this case, how do you implement this into cessation, into practice? There's the 5 A's model where you ask, advise, assess, assist, and arrange. I won't go into too many details about that. However, when you look at the implementation of this, we've suggested potentially useful questions. Right now, there is not a standard recommendation for what questions you would incorporate in clinic, but these are questions that are useful to try and identify tobacco use. This would give you an idea. Question 1 would be a good question for ever tobacco use. This question 2 really helps identify current tobacco use, and so forth and so on. So there's questions here that can be useful to help you define tobacco use currently and tobacco use history. And then based on how patients respond to tobacco use, all patients who smoke, and in our opinion, patients who smoke within the past 30 days, because these are patients who are extremely high risk for relapse, you would advise to quit smoking, assess willingness to quit, assist patients, and arrange follow-up. And then you would plug them into this clinical paradigm where you would continue to follow patients repeatedly and encourage cessation support. And it's also important to remember that patients who quit, you want to try and encourage them and tell them that they've done a good job with quitting and maintain abstinence and prevent relapse, because relapse prevention is something that's very important to ensure in your patients who have successfully quit smoking. So I'm not going to go into too many details about the fundamentals of smoking cessation. One of the keys behind this lecture today, because we are hopefully mostly clinicians, is to urge you how important it is to consider tobacco assessment and cessation in your standard clinical practice. All patients who use tobacco should receive evidence-based cessation support. These would include repeated structured assessments where you really try and identify tobacco use in a good, reproducible manner. Repeated advice to quit from all clinicians. It helps whenever a surgeon and a medical oncologist and a nurse and social worker and the whole clinical team advises patients to quit smoking and encourages them when they make progress. Behavioral counseling and pharmacotherapy are mainstays to increase tobacco cessation efforts. With regards to behavioral counseling, trained counseling is the best thing, but even brief counseling helps. It's important to try and repeatedly encourage patients to quit smoking and discuss with them some of the difficulties they have, and it does not take 45 minutes or an hour to do that. You can do this quickly during weekly meetings and really congratulate them on progress. There are 7 different pharmacotherapies. Nicotine replacement is one of the mainstays. Varenicline or Chantix is also an evidence-based cessation support. I put in, again, I have no financial relationships here. Bupropion is another effective pharmacotherapy for cessation support. And then cytosine is actually a nice cessation-based agent. And I highlighted this one because just recently, down here at the bottom, there's a paper in the New England Journal of Medicine that came out in December that actually suggested that cytosine was superior cessation agents compared to other cessation agents. So cytosine is a very inexpensive product that's available primarily overseas, but if you're in outside of the United States, this would be another product that could be very useful. Follow-up is very important. You know, one type of cessation or one day or one effort for cessation support is not as successful as repeated efforts to try and quit smoking, and patients should be congratulated on progress. I bring this up because, and this right here in parentheses, you got to remember a lot of the smoking habits that are developed and maintained in clinical practice, or excuse me, in cancer patients, are habits that started when people were teenagers. And from a little bit of perspective, just imagine having a habit that you started as a teenager and has lived with you for 30 or 40 or 50 years, and then you're diagnosed with cancer. It would be extremely difficult to quit. So remember that repeated attempts and encouragement are important to try and help provide cessation support for cancer patients. I'm going to put in one small slide about e-cigarettes. The IASLC, AACR, and ASCO all in this past year have developed guideline statements for e-cigarette use. I just want to emphasize e-cigarettes, you may know, are electronic devices that deliver aerosolized nicotine and other chemicals through a heating element. However, the important things to remember is that right now we really don't know the benefits and harms associated with e-cigarettes. Research is needed on these. The health effects are unknown. The effects on tobacco use and cessation are unknown, and the products are extremely rapidly evolving. These products come out almost on a weekly basis. You have new products that come out. So with regards to tobacco use, behavioral counseling and pharmacotherapy remain as the current evidence base for cessation support. Those are the only evidence-based methods that we have for cessation support. I always have this slide, this is one of my favorite slides, that points out some of the obvious. I hope some of you all get a laugh out of this. Here we see the statistics show that teen pregnancy drops off significantly after age 25. There's this composite here, which I actually think is my tobacco composite. Looks like a fairly suspicious person. And then, of course, the Utah Poison Control Center reminds everyone not to take poison. Sometimes in all of the complexity of cancer care, sometimes maybe we forget some of the simplest things that might make some of the biggest difference. And with regards to tobacco use and smoking, this is something that may be one of the most important things we can do to improve outcomes. Smoking causes adverse outcomes in cancer patients. There's biology that demonstrates that tobacco products activate tumorigenic pathways and make the effects of chemotherapy, radiation, and cytotoxic therapies less effective. The effects of tobacco, both the clinical and biologic effects of tobacco, appear to be reversible. And so if a person is smoking at diagnosis, it's not too late to quit. Whether you improve therapeutic response, overall mortality, toxicity from treatment, all of these things are clinical benefits for our patients. So quitting smoking is important. These effects are reversible. Tobacco assessment and cessation are unfortunately not regularly incorporated in clinical trials or clinical practice, and this is an area we need significant improvement with. However, it's also important to remember, addressing tobacco use does not have to be time-consuming or difficult. Even brief advice can significantly help patients. It's obviously best to try and get patients into a more intensive program when they need help, but repeated advice, assistance to quit, behavioral counseling, and pharmacotherapy are relatively easy and not terribly time-consuming activities that can significantly improve cessation in cancer patients. And this is the thing that I would have as a take-home point. In all of the things that we do for our cancer patients, all of the targeted therapies, all of the extremely invasive procedures that we use, smoking cessation may be one of the best methods to improve cancer treatment outcomes for cancer patients as a whole. And it's something that is very cheap, it's widespread, and I would absolutely encourage everyone to have a conviction to provide cessation support for our cancer patients. And with that, that's the end of my presentation, and I'll be happy to take questions.
Graham, that was just completely terrific. As I was listening to it, as some key messages that you said, that it's never too late to quit. And I'm thinking back to that odds ratio that you showed of 3. And we could look at other treatments, and 3 is a pretty phenomenal odds ratio to show the impact of tobacco cessation. So, you know, one could argue maybe it's the most important treatment. But let's go to some of the questions. And because, Graham, you're not going to be surprised by the first one. This is one that we've talked about a lot. It has to do with electronic cigarettes. So you address the slide towards the end. But the question is, so if people won't quit their cigarettes, what do you think about E-Cigs?
This is actually a question I've heard probably 50 times over the past year. This is a very slippery slope. The evidence base that we have, we know that smoking causes adverse outcomes, and we also know that the evidence-based methods to provide cessation support are behavioral counseling and pharmacotherapy. Right now, we just don't have any evidence base for e-cigarettes right now. I'm going to preface this with common sense would suggest that smoking is unquestionably probably the worst thing. And with less chemicals, e-cigarettes would probably be safer. Common sense would suggest that. Right now, from a medical standpoint, we don't have any evidence base that we can rely upon to say that e-cigarettes are better or worse, or whether they help people quit smoking or if they help people relapse. With regards to quitting smoking, there are actually studies that suggest that e-cigarettes help people smoking, at least in the short term. But longer-term follow-up in cancer patients, there's been a study that suggests that e-cigarettes actually, people who use e-cigarettes actually return to smoking 1 and 2 years after they have quit. And so we unfortunately just don't have the evidence base for e-cigarettes. I wish I could give you recommendations otherwise, but until the evidence emerges, it's a very slippery slope and difficult topic. I would say this. I absolutely encourage everyone to stop smoking. And if I had a patient who was using e-cigarettes, I would say absolutely stop smoking. As a matter of fact, I have patients using e-cigarettes. I tell people, absolutely don't smoke. The best thing to do is to use FDA-approved medications such as nicotine. How can I help you use these medications? If they don't want to use those and they want to use e-cigarettes, I say, I can't support you using e-cigarettes, but absolutely don't start smoking again. Make sure you stop smoking.
So, I'd agree with you that for the cancer patient, so because even in electronic cigarettes in the general population, the data is quite mixed on the efficacy for cessation. So here's one of the other questions, and this drills down a bit more, because they're asking, what about varenicline or cytosine, which are nicotinic acetylcholine agonists or partial agonists? And, so that's working on that nicotinic acetylcholine receptor that you were talking about that nicotine stimulates, which the e-cigarette nicotine would stimulate, and that's kind of like bad for the cancer cell. So what do you say about varenicline or cytosine?
In this case, I actually, for the patients that we have in our cessation program, if we have patients who are smoking, I will gladly give the nicotine replacement, varenicline, or bupropion. The cytosine in the United States we don't have available, so we can't use that. And the rationale behind this is that, one, the concentrations of components that activate the nicotinic receptor are probably less. You don't have NNK. You don't have other agonists of the nicotinic receptor in nicotine, varenicline, and others that you would have in cigarette smoke. B, they're proven cessation aids, and I do think that smoking is definitely worse than nicotine replacement, bupropion or otherwise, which also leads us to 3, there's never been a single study that demonstrates that nicotine replacement or varenicline or bupropion has an adverse outcome in cancer patients as compared with smoking. And what I mean by that is that I don't know of a single study that's ever shown that any cessation agent is worse than smoking. The reason I gave the nicotinic receptor study or nicotinic receptor discussion in such detail is that it's important for people to realize, one, that this is one mechanism that we may promote tumorigenesis through cigarette smoke, but also we need to get people to quit smoking, and once they quit smoking, they need to get off nicotine. Nicotine does not need to be a lifelong habit. This is something that once we get them to quit smoking, they need to be weaned off nicotine and nicotinic receptor agonists. So it's a very complicated biologic question, but I will say that all my cancer patients who smoke, I will give them nicotine replacement, varenicline or bupropion, and I absolutely feel it's safer than smoking, without question, safer than smoking.
Super, super. I think that's really key. The other thing, too, that you said in there that I'd like to emphasize, too, is you mentioned nitrosamines. So nitrosamines, which are also a very strong stimulant for the nicotinic acetylcholine receptors, and that's not in the other products, too. So, as you said, quitting smoking is just the most important thing, hands down. There's one question here, is cytosine approved in the U.S., and it's not in the pipeline for approval. Other countries, and this is something that's being looked at internationally, but so the cytosine is not approved in the U.S. At the present time, nor as far as I know. I don't know of it being in the pipeline for it either. Okay, so let's go to another question. So this question is about the, and you actually sort of addressed this, based on the biological effects of nicotine, would you recommend that they not be prescribed nicotine replacement therapy? And I think you made that very clear that yes, the most important thing is to come off of cigarettes, and you don't care whether it's NRT, nicotine replacement therapy, or bupropion. Either one of them you're comfortable with as long as the patient stops smoking. Is that basically what you were summarizing?
That's correct. I have over 400 studies that show that smoking is bad. I don't have a single study that shows that nicotine replacement, varenicline, or bupropion is bad. So we're going to have to do a lot of catch-up for me to change my mind on that one.
Okay. All right. So now this was one that it was an interesting question because it says, is it too early that we have information about nicotine from e-cigarettes on radiation therapy or chemotherapy? And when that question says, what studies are going on in this area? And it made me think of the information that you presented earlier that we don't even have clinical trials asking about smoking, much less e-cigarettes. And I'm wondering if you want to emphasize, again, the importance of putting tobacco use questions or e-cigarette use questions into clinical trials.
It is absolutely critical that we put these questions into clinical trials. And the reason being is that we have a very high chance of having either false negatives or possibly false positives in our clinical trials design, simply because current smoking may decrease the effectiveness of one or more targeted agents or cytotoxic therapies. Not only that, but the effects of smoking are reversible. So we have an effect modifier, which means that the effects of smoking are permanent. If a person smokes and then they quit smoking, and the dynamics effects of smoking on therapeutic response, recurrence, survival, toxicity are largely unknown. And clinical trials are designed to try and capture those primary and secondary outcomes. So they absolutely should be put in all clinical trials, breast cancer trials, prostate trials, GI trials. If we find areas where smoking does not make an effect, great. I mean, that would be a good thing to know. So negative results are still positive. At least we can use them for useful clinical interventions. So absolutely, we should put these in clinical trials.
Well, here's a question that goes along with that because, this is an international webinar, and so we know that their smoking prevalence rates in populations vary from country to country, and so therefore the smoking prevalence rate at the time of diagnosis of lung cancer varies tremendously too. So say if you have, in the U.S., less than 20% of people are still smoking at the time of their lung cancer diagnosis. I think that's one of the latest numbers. But is that number the same as in, let's go to Hungary, which has a very high proportion, a high prevalence of smoking and lung cancer, or what about Australia or Japan? So it's another reason maybe that we need to make sure on our trials, to compare trials internationally, that we know who's smoking and who's not.
Well, you're exactly right. The prevalence of smoking can change certainly from country to country and based on their population characteristics. Also, we and others have shown that about 30% of people who are current smokers misrepresent tobacco use in cancer populations. So the estimates of 20% of lung cancer patients smoke, in reality, probably 30% smoke, just because the self-reported smoking status is often misrepresentative in current smokers. So there's a lot of questions that could be answered, but just getting good structured questions into clinical trials would be an excellent advance, and tracking tobacco use at follow-up, those would be the highest yield, lowest
cost
type of interventions, or types of things that we can put into our clinical trial design right now.
Would you recommend doing a biomarker, like measuring cotinine in a clinical trial in order to?
I think cotinine is something that can be performed in urine, blood, or saliva, which is an evidence-based method to confirm exposure to nicotine, which usually corresponds based on how much cotinine is present, can really help tell who is a smoker versus using nicotine replacement. Exhaled carbon monoxide is another marker that is an evidence-based marker for smoking status. The benefits of exhaled carbon monoxide is that it's very quick. It gives you a quantitative assessment. It can be done in real time, whereas unfortunately cotinine many times requires a longer period of time to get the result back. So I think the use of a biomarker could be good. Personally, myself, this is my opinion because there is some contention, I think that the use of a biomarker should be restricted to people who say that they have quit within the past year or who have reported current smoking. In our studies and other studies, it suggests that those people would be the people who would benefit most from biochemical confirmation. Never smokers, biochemical confirmation probably has an extremely low yield, and people who quit 5 and 10 years ago probably also has a low yield. So I think there is a place for it, but I think the place should be selected carefully.
Okay. What do you think about withholding treatment from patients who aren't willing to quit, that they say, no, I'm not quitting? What do you think about whether they should be treated or not?
Well, I'm going to change that question just a little bit. I'm going to say, what do I think about patients who say, no, I'm not going to be quitting, and what am I going to say to patients who are smoking and say, yes, I'm quitting right away? And I'm going to go back to that one slide that I showed you on the effects of smoking and the reversible effects on therapeutic response. This is exactly the question we should be asking. Does delaying treatment in people who are going to quit, does delaying treatment for 3 or 4 weeks, does that improve therapeutic outcome? Does that improve tumor control rates? That's exactly the question we could ask, because the biology of tobacco doesn't necessarily get better in 1 or 2 days, but there are some studies that suggest somewhere between 2 to 4 weeks after cessation that clinical side effects improve. So it could be useful to possibly delay treatment for a short period of time in patients who are not, who don't need a treatment immediately. Now, the other situation where a person says, I'm not going to quit, I'm going to keep smoking, I think in that case, we need to treat patients with the best cancer treatment that we have. I certainly can't recommend otherwise. We've got to encourage them to quit, but unfortunately that's their choice. So I think the delay in treatment, particularly in patients who say that they're going to quit and do quit, is an extremely interesting question that may manifest in some very good clinical benefits. But unfortunately, we haven't had a trial or a specific design to address that. This mostly comes out of a few series from institutional series that suggest a short period of time may be very beneficial.
Excellent. So this next question goes to, I think, something that was in the Surgeon General report. So the question is, are there published studies showing improvements in lung cancer survival when patients quit smoking? Are there prospective studies tracking patients who quit versus don't quit?
There are studies.
Go ahead.
They are, but they are not clinical trials that have shown improvement in survival, and no randomized studies that show that cessation improves survival. This is a little bit of a frustration, at least in the United States, and what I mean by that is that probably some of the very best trials that we could implement in cancer patients right now would be to evaluate what the effects of smoking cessation are on clinical cancer outcomes. Most all of the cessation trials are really based on tobacco use behaviors, but not on clinical cancer outcomes. And so we really need a few good studies that demonstrate that smoking cessation improves a clinical outcome. And what I mean by that is it may show that reduction in smoking, if we go from a pack a day to less than 5 cigarettes a day, for instance, might show a clinical outcome, so an improved clinical outcome. It may show that it takes 2 to 4 weeks of cessation to improve clinical outcome. These types of time and dose-dependent behaviors we really don't have a good handle on. And so there needs to be a few very well thought-out clinical trials that really test the effects of smoking cessation, specifically the time and dose-dependent effects. The studies that have been published all suggest that smoking cessation improves outcome in cancer patients. There have been a few head and neck studies, a few lung cancer studies, and those are the ones that are of note. But unfortunately, we lack good, well-designed clinical trials to show this. So hopefully we can encourage people to think a little differently on some of their clinical trials design.
So when you're saying treatment, you mean whether it's radiation therapy or chemotherapy, people do better with chemotherapy or radiation therapy or the combination if they quit. That's what you're saying.
In this case, we don't have all of those figured out. We have a few surgical series. We have a few radiotherapy and chemoradiotherapy series that show that either toxicity, mortality, or recurrence improve with cessation. But what the Surgeon General's report really shows is that current smoking is worse than former smoking. And that's one of the conclusions of the Surgeon General's report, is that quitting smoking improves prognosis. It absolutely does. People who quit smoking do much better than people who are current smokers. So the trials need to consider this And certainly I don't think anyone would suggest continued smoking would be a good idea. So that's where the evidence base is right now.
We have a note from one of the attendees who's saying that they're from South Korea, and basically they were looking through their lung cancer clinic trials as a thoracic radiologist, and there was no data or anything about tobacco use during the chemotherapy for lung cancer patients. So it's not just in the U.S., and we believe this is a global problem, that the use of tobacco just isn't even in the treatment paradigm, which I think has been the emphasis of your talk, that it should be. So let me see, there was one other question that I thought was quite interesting. So looking at depression in cancer patients who are smokers, you know, what do you think about the patient diagnosed with lung cancer, depression? Are they more likely to be smoking? Is it a person who's depressed that is smoking? Do they do worse? What do you think about that question, the combination of depression and smoking in lung cancer?
You know, the question of depression and smoking, it's hard to link depression, smoking, and lung cancer in the evidence base. However, we know that smoking and lung cancer patients do worse than people who continue smoking. We also know that people who smoke have a much higher incidence of psychiatric comorbid diseases such as depression, and depression can make it much more difficult for people to quit smoking. So there is a need to, if you have a lung cancer patient, assess for smoking, and in the people who smoke, and in all patients, but particularly people who smoke, we already know that there's a higher risk of comorbid psychiatric disease, and so it's an opportunity to ask about depressive symptoms, anxiety, things like that, because they may benefit from the addition of psychological therapy or psychiatry support to try and help with some of their psychiatric comorbid diseases. So it's exactly a good, I'm hoping that helps answer the question. It is important to consider them together, but I would open it up to beyond depression. I'd open it up to psychiatric comorbidities on a much larger scale.
Yes, and I think what you're saying is quality of life has been shown to be better too, as people are quitting smoking. And obviously, if you have a better response to therapy, you probably are going to have a better response on your quality of life. So here's a question that has just always been puzzling. Why aren't cancer centers doing more to prevent cessation treatment? You went through a program that you had set up that was very effective, and as you had said, wasn't all that hard. It's kind of like, brief intervention. So why aren't more cancer centers around the globe addressing tobacco cessation? Since about 30% of all cancers are caused by tobacco, and I know we're not talking about causation, but, that means a fair number of people coming in the door are using tobacco. Why aren't cancer centers doing something about it?
I think that's a very complicated question. I'm not trying to defer the question, but what I'm getting at is that I think the environment that the cancer center's in, the country, the tobacco control policies, the politics, they may affect cancer center policies. I think there's practitioner burdens or barriers, and what I mean by that is some practitioners don't feel trained, or they don't feel like they have time or resources. A lot of practitioners feel that patients are not receptive to cessation support. I presented the study earlier that showed that in a mandatory assessment and referral program, more than 90% of patients were receptive to intervention. I'll also note that we reproduced the program here at the Medical University of South Carolina, and 92% of the patients in a mandatory assessment and referral program are still receptive. So I don't think there's any evidence that suggests that people are not receptive to intervention. Perceptions of the practicing oncologist, I think, can limit it as well. I will say one thing. I'm not aware of data behind this. There may be data there, but in my experience and experience of some colleagues, I will tell you this, that when a new diagnosis is presented to a cancer patient, telling patients they need to quit smoking, and in our practice, saying that they're automatically referred in the cessation program helps. But I think it also helps to have a cessation specialist contact them a few days later. I think that patients, once they have absorbed a new cancer diagnosis and realize they may be able to do something to improve it, once they have a chance to get over that shock for a few days, I think patients are very receptive to try and help themselves improve. So I do think there's some dynamic factors that can help this. Now, why do cancer centers not do this? In addition to those, one of the biggest arguments I hear in the United States is how do we bill for this? How do we collect revenue to support it? And unfortunately, cessation does not collect revenues very well in the U.S., but it has a significant cost savings, very likely has a very significant cost savings on the back end if it can produce those complications. So cancer centers, I think, have so many different influences outside of the institution and even within their practitioners that I think there's several reasons why they haven't expanded this in a much bigger sense right now.
You know, so one of the comments that you made that I had found really true, that this is something the patient can really take up. It's something they can do. When you come in with a lung cancer diagnosis, oftentimes you know, much is left in the clinician's hand or in the cancer center hand, et cetera. But this is something the patient can really do that can significantly impact. So it might be, you know, how it's phrased, but it might empower the patient to help their own therapy if they're really addressing their tobacco cessation. And again, you know, we have talked about this too, making sure that there's no stigma, you know, there's no guilt. This is all about the best outcome possible.
You're exactly right, and I think that this is one of the things that the patient has 100% control over. So this really does, I know it may sound a little hokey for lack of a better term. This really is one thing the patient can do that might improve their survival, it might improve their cancer treatment response, it might decrease their toxicity and improve their quality of life. This is all in the control of patients themselves. And so it really does give an opportunity to put power back into the patient's hands.
Well, Graham, this has been fantastic. We've had a lot of good questions, but I think we're getting ready to wrap up. I would just like to thank everyone for attending. Thank you very much, Dr. Warren, for this presentation, and remind everyone that there actually is another webinar on electronic cigarettes in cancer patients. So a whole session on it on April 1st at 8 p.m., and you'll be hearing more about that through different emails, et cetera. So look forward to April 1st on electronic cigarettes. So again, thank you very much, Dr. Warren. Thank you, IASLC, for allowing us to have this presentation, and everyone for attending. Thank you.
Thank you, Carolyn, for doing a great job, and thanks, IASLC, for having me.
All right. Bye-bye.
All right. Bye-bye.